Hi everyone. Um, so we are going to continue by talking about trauma management, and it's important for us to remember that the um, advanced traumatic life support algorithm is divided into two phases: the primary survey and the secondary survey. And the primary survey is majorly concerned with the initial resuscitative measures, which is um, instituted to stabilize the patient, and also um, identification of injuries that might have occurred to that patient. While the secondary survey is just more like the head to toe assessment, that we do to identify any gross, injury that might have been missed in the primary survey and any adjunct um, investigations we might want to do. Um, we should not forget the ABCD approach: the airway, the breathing, the circulation, the disability, and the exposure that we do. And for the primary survey, and the fact that the airway component is the most important. That we have to ensure that has been taken care of first before we move to the other one. We should not forget the fact that anybody with a GCS score of 8 or less needs to be intubated. It is very, very important. So looking at the component of the primary survey, the airway is the most important and is the first one we are going to be talking about. So um, a patient that suffers trauma, the first thing you want to do is to assess the patency of the airway. So you want to talk to the patient. Hello, sir. Hello, ma. How are you doing? Can you hear me? If the patient responds, good, the airway is fine. You can move to the next. But if the patient does not respond, you have to have it at the back of your mind that there's a tendency that there is a compromise of the airway. So, four things will run through our mind. The first one is the structural airway damage. The second is when you have airway compression. The third one is somnolence from a low GCS score. And the last is when the patient has a thermal or inhalational injury. So, any four of these can cause a compromise of the airway. So, think about it. Either the airway is damaged, the airway is compressed, the person has problem maintaining patency of the airway. They have no control over it again because they are now somnolent, like low GCS score. Then the fourth is inhalational or thermal bone injury. So that in a way too is should be under structural airway damage in a way, but it's good, it's separated. So the structural airway damage, I just want us to see it as problem with the tracheobronchial tree. There's a rupture, there's a damage to the tracheobronchial tree. And when there's a rupture to the tracheobronchial tree, what happens? There's leakage of air into the tissue surrounding the airway, right? And we begin to perceive some changes like crepitus, right? Just like we normally say, as if you are stepping on dry leaves. You see, you hear crepitus due to the hair tracking around the tissue planes, right? Gargling noises when the patient is breathing. Evidence of the subcutaneous emphysema. You can even feel it. You see swelling around the neck. You can, feel those hair tracking around the tissue plane due to the rupture of the tracheal or the bronchial airways. Also, structural airway damage can also happen in people with facial trauma, in which you have blood occluding their airway. So that's why one of those things you want to do is to suction. You know, even it might be blood, it might be foreign body, debris, anything. You want to suction, you want to do your basic airway maneuvers to open up the airway, like doing your jaw thrust, your chin lift, and the like. So structural airway damage can come from rupture of the tracheobronchial tree or facial trauma with blood, occluding the airway. Then you want to think about compression of the airway. So what are those things that can elicit external compression? The most, you know, um, significant example is a patient with a penetrating neck trauma, like maybe from a gunshot, maybe from stab injury, and there is maybe dissection of the carotid or injury to the neck vessel, and you have bleeding around that area with hematoma formation. So the hematoma can easily compress on the tracheal, and of course, it's going to obliterate it, the diameter, the lumen of the airway. So we are going to see difficulty of air entry into the airway. So the patient will start presenting with hoarseness of voice, right? Dysphonia, like stridor, due to the upper airway obstruction. and you can see evidence of the source of that obstruction, like expansion of a neck hematoma. So an expanding neck hematoma is one of the hard signs of penetrating neck injury. This is not a patient you want to start rushing in for CT. No, you want to secure that airway first before you now take into surgery for surgical exploration. Very, very important stuff. So dysphonia, hoarseness, stridor, are all pointers towards airway compression. And this might not come from um, a neck hematoma alone. It might even come from infectious process like a child having epiglottitis. Inflammation of the epiglottis can occlude the glottis, the larynx, and it will be very difficult for hair to get into the airway because of the compression. So just like we have here, we have inflammation of the epiglottis here, and there's obliteration of the airway, and it's difficult to get in here across. So somnolence because of people with low GCS score. So somebody that suffers maybe penetrating neck injury, suffers a stroke, suffers, although because we are talking about trauma here, we might not make reference to stroke. So penetrating head injury, even head injury, penetrating neck injury, you know, um, um, you know, just think about injury to the head and neck usually, and the the individual becomes somnolent with a low GCS score. In that state, it's very difficult for them to control the patency of the airway. So they lose control totally, and there's a high tendency for the airway to collapse. So you don't want that to happen. We want to quickly consult to ICU, or find a way to secure that airway as soon as possible by intubating that patient. So once you get the GCS score to be 8 or less, you must definitely intubate the patient. And this is just an overview of how to calculate the GCS score. The high opening is the lowest, 4 is the maximum you can get. Next is the verbal, 5 is the maximum, and the motor, 6 is the maximum. So looking at the high opening, um, the minimum the patient can get is actually 1 for the 3, and the maximum the patient can get is 6, which is for motor response. So even if the patient is not reacting at all, the minimum is going to be 3, because it's going to get 1 from high opening, 1 from verbal, 1 from motor. So looking at the high opening, you are assigning for a score of 4 if the patient opens his or her eyes spontaneously. So if the patient opens the eyes only to command when you call, 3. If you call, the patient doesn't open, but if you try to inflict pain, the patient opens 2. If the patient doesn't open at all, that's 1. For the verbal, you try to talk to the patient, ask him where is he, what time of the day is it, all those kind of things to establish orientation in time, place, and person. So if the patient is well oriented, assign a score of 5. If the patient still talks to you, but there is an element of confusion or disorientation, that's confused speech, assign a score of 4. If the patient makes some, few sentences, but they don't have any logical meaning and they are not even conversational, give a score of 3, because those are inappropriate words. If the patient just mumbles words, just make some like sounds, not comprehensible, that's true. If the patient doesn't do anything at all, that's 1. For the motto, you can talk to the patient. If the patient follows your command, raise your legs, raise your arms. 6, you try to do a sternal rub, and the patient kind of brings his hands towards that area, localizes the pain to that area. That is 5. If the patient just withdraws his hands, away from the pain, that is 4. If the patient flexes the arms, but the legs are extended, that is a discorticate posturing. So that is 3. If the patient extends both the arms and the legs, the cerebral posturing, that is 2. It's one of the signs of severe brain injury. So you give a score of 2. Then if nothing at all, 1. So the last is a thermal or inhalational injury. We have talked about this so many times. You are evaluating the patient. Maybe the patient was involved in um, you know, a burning building, and they are locked in that area for a long time. They must have inhaled a lot of um, toxic gases, and you are looking through their face. You are seeing singe, burnt facial or nasal hairs. Burn injury around their face. You open their mouth, you are seeing soot, carbonaceous sputum, right? So this is a patient you need to consider for intubation as soon as possible because there's a high tendency for laryngeal edema to be setting in. So and once there's edema of the airway closes, becomes less patent and high risk of dying. So you quickly need to arrest and secure that airway as soon as possible. As soon as you get any of these, the cinch facial nasal hair, um, the bones around the face, carbonaceous sputum, very, very important. You even do that, you do that before you give fluid. We have talked about this because if you give fluid, the fluid will worsen the airway edema, and it can worsen the situation. So you have to secure the airway before you even start considering fluid. Very, very important. Now, we have established the fact that this patient has um, structural airway injury because we were able to feel for the crepitus. We are able to establish the fact that this patient has airway compression from maybe penetrating neck injury with an expanding hematoma. We are able to see that this patient has a low GCS score, less than 8. We are able to get the history that this patient, was involved in bone injury and the response of singe nasal hair, carbonaceous sputum, facial bone, and we want to intubate. So what do we want to do? We want to choose the endotracheal intubation first. That is the most preferred method, right? Except in some conditions, like when you have rupture of the tracheobronchial tree. In that situation, you might want to do another thing too. But in most situations, the first is to do an endotracheal intubation. That's the most preferred method. Even in the setting of cervical spine trauma. Yeah. So what you are just going to do in this situation, if there's a blunt injury to the head and you are suspecting, or there's a gunshot injury to the neck and you are suspecting, injury to the cervical spine, and you want to do your endotracheal intubation, what you can just do is just to immobilize manually, you know, the head while you do your endotracheal intubation. Because if you have your cervical collar on at that point, it might pose a difficulty, towards the intubation process. But you can get somebody to manually stabilize the neck while you do your intubation, right? Um, but in some situation, like when there's a rupture of the tracheobronchial tree, you might not want to do your endotracheal intubation, but the intubation approach you might want to do is to do your nasotracheal intubation with fiber optic bronchoscope because in this condition now, you know that the airway is going to be very difficult because it has ruptured. So you need to use a scope, to maneuver yourself through the airway. Then you go through the nose, down to the tracheal. So don't forget, when there's rupture of the tracheobronchial tree, don't go through, the endotracheal approach. Go through the nasotracheal approach with the fiber optic bronchoscope. Very, very important. The bronchoscope will help you to maneuver through that airway, right? But this is contraindicated when the patient has basal skull fracture. So when there's basal skull fracture, maybe fracture to the temporal bone, sphenoid bone, the ethmoid bone, we are going to talk about it, I think, when we move downwards a little. So, and you are getting the patient having arterial or having rhinorrhea, with CSF leakage, you suspect basal skull fracture in that kind of patient, or there is the raccoon eyes, the periorbital ecchymosis, or there's the battle sign where you see hematoma just beneath, just behind the hair at the mastoid process. So you know that there's a high tendency of the patient having basal skull fracture. So you don't ever do your nasotracheal intubation for that patient because if you pass it through the nose, there's a tendency of it moving upwards to the cranium, yeah, to the brain instead of moving downwards to the trachea, because all the structures that form the nasal bone too are very much involved in forming the base of the skulls, like For example, the ethmoid bone, the sphenoid bone, they are involved in, forming the nasal compartment around, as well as the base of the skull. So fracture within any of these bone can easily cause dislodgement of the scope or the tube, into the trachea cavity, and you don't want that to happen. So if it's very difficult to do nasotracheal intubation or endotracheal intubation, you might want to consider emergency cricothyroidectomy. So this is just making a small incision within the cricothyroid membrane to access the airway. It's very, very easy. So that should be the next thing to pick. So whenever any of these cannot be done, please, the next thing to pick in the option is cricothyroidectomy. So please don't pick emergency tracheostomy. They will never put us in the situation of going for emergency tracheostomy. It's never to be done. So choose cricothyroidectomy instead. Then after securing the airway, the next thing is to check for breathing, right? The patient breathing. So two major stuff you are concerned with: oxygenation and ventilation, oxygenation and ventilation, oxygenation and ventilation. So for the oxygenation, you want to quickly check for your oxygen saturation. You plug in your pulse oximetry, you know, and you your SpO2, so you can check for your oxygen saturation. Then you can assess for ventilation, check your respiratory rate, the quality of the respiration, right? You might quickly want to do some quick examination. You want to look at the neck, right? JVP, is it elevated? Because that could be suspicious for maybe the patient having, a tension in pneumothorax somewhere, and you quickly want to do a needle decompression. You want to look at the JVP, you want to look at the trachea. Is it deviated to any side? You want to quickly do percussion notes. You want to quickly percuss the lung to see if there is maybe hyperresonance or dullness, somewhere. Because if there's hyperresonance, you think about pneumothorax. If it's dull, you might think of an hemothorax, right? Blood collection within the pleural cavity. Then auscultate for the breath sound. So if the patient has bilateral breath sounds and a good chest rise, but the patient is not oxygenating, so you still need to intubate or mechanically ventilate that patient, right? Because the patient might have ARDS, and the patient might still be ventilating, but the patient is not getting oxygen. The PiO2, the PaO2 is still low. So you have done nothing. So we still need to intubate that patient and mechanically ventilate that patient. So if a patient has unilateral breath sounds, very, very important stuff. If the patient has unilateral breath sounds, you have to think of either pneumothorax or hemothorax in a trauma setting, right? Unilateral breath sounds. It's either of these two. Like they like talking about it a lot. And of course, we know what to do to differentiate between them. So from your percussion, you're able to tell because of the resonance you get with your pneumothorax due to the hair, and of course, because of the blood, you are going to get a dull percussion note for hemothorax. So, dull percussion note for hemothorax, resonance for pneumothorax, that should raise your suspicion. And you are going to do two different things, right? If you have large pneumothorax, no tension, place your chest tube. Hemothorax, large hemothorax, place your chest tube, right? If there's tension, you don't place chest tube first. The first thing is to do a needle decompression. And how you are going to know there's tension is you are going to see the tracheal deviation, right? You are going to see the raised JVP. You can also observe for the hypotension that is going to happen because of the obstructive shock, right? So you can verify with your chest X-ray if only if the patient is stable. That's when you can verify with your chest X-ray. So how you quickly want to know if the patient is stable is just to quickly look at the blood pressure, right? Look at the blood pressure, look at the pulse rate. So that can tell you. Once you see that the patient is hypotensive, having blood pressure less than 100, so you might not need to be doing your chest X-ray. You want to quickly, intervene to bring the patient out of that situation. So just like we have said, you insert your chest tube to decompress the lung, and drain any fluid or air that is accumulating within that pleural space. So if the patient is hemodynamically unstable and you are suspecting a tension pneumothorax, you have to do a needle decompression first before you now place your chest tube later. It's as simple as that. Um, so other situations can also arise. For example, after your intubation, if you notice that the patient still has unilateral breath sound, particularly on the right side, think of a right endobronchial intubation. That is, the right side is actually the shorter, the wider, and the straighter. So there's a high chance of the tube just going directly into the right, and you are going to be intubating that area only. That is the part that is going to be getting the hair only. So the left side might collapse, right? And how you are going to know is that you just see that you're having breath sound only in the right. You are not having any breath sound in the left. So it means that the person has done a right endobronchial intubation. So what you need to do is to pull up the tube, the endotracheal tube, pull it up just few centimeter, like 1 or 2 centimeter above the carina. That's where it should be, so that you can have equal entry of air into the right and the left bronchus. So please, the carina is the point where the bronchus bifurcate. So you have to make sure that your tube is just 1 centimeter, 2 centimeter above that carina, so that it can enter the right and the left bronchus equally. So uh don't forget, like I said, if you do a right endobronchial intubation, the left lung can collapse from, that obstructive atelectasis, because air is not going to enter that lung. With time, it's going to collapse. The remaining air that is there is going to be resorbed, and the area is going to collapse. So you want to ensure that you do your chest X-ray to confirm that the endotracheal tube is just um, um, above the carina. So if you do your x-ray in somebody that has these unilateral breath sounds in the right side, after you have intubated, you will see that that tube will be below the carina, protruded into the right side. So you have to make sure that you withdraw the tube above the carina to ventilate both lungs. Very important. So moving on to the circulation, this is just talking about your cardiovascular status, right? So you want to evaluate for shock, right? So in which you expect your systolic blood pressure to be less than 90, you know, the pulse is going to be fast, it's going to be tready, the patient is going to have weak pulse, there's going to be diaphoresis, that's also the time to initiate, um, measures to quickly, put in fluid blood into that patient, and also do your ECG monitoring. Very, very important, right? Very important. So, the three common causes of shock in trauma that we need to know is what? Hemorrhage, hemorrhagic shock, tension, pneumothorax, which is going to cause an obstructive shock. Then last one is cardiac tamponade. So those three stuff, should run through the back of our mind. That is where the question stem is going to be focused. A patient with trauma, maybe to the chest, and suddenly, comes down with shock. So it's either one of these three: hemorrhagic shock, tension pneumothorax, or um, cardiac tamponade. So for the hemorrhagic shock, that is the commonest cause of shock in them, in trauma patients, commonest shock. And there are 5 compartments of the body that, are big enough to take in, blood volume to accommodate, you know, those collections. So that is the chest, the abdomen, the pelvis, the extremity, particularly the thighs, and of course, external bleeding, the floor. So the chest, you come up, the chest, the abdomen down, the pelvis, right? The extremities, the floor. So it's just like a continuous thing. Just look at yourself: the chest, the abdomen, the pelvis, the extremity, and the floor. So you don't think about the brain, because the brain is more like a closed valve. It cannot expand to take in, the fluid, the blood. So what is going to happen is there's going to be ventral coning, because there's going to be inhalation. The brain cannot, the vault cannot expand to take in so much blood volume. So you cannot have hemorrhagic shock into the brain, right? So brain inhalation will have happened, and the patient will have, died before, you know, a significant amount of blood volume accumulate, to cause shock. So what you want to quickly do once you notice that this patient is already having hemorrhagic shock is to what? Quickly set off two large bore cannula, just like we normally talk about. If one has been set the other one. So that should be two. That should be two. So set up your two eyeball cannula, 16 gauge or larger, then give a bolus of 2 liter of isotonic crystalloid, sodium chloride. Better if you have your Hartmann solution, right? Ringer's lactate, you give. So very important to quickly, restore hemodynamic status. And if the patient is still unstable, you need to transfuse packed red blood cell. After you have given you 2 liters of your isotonic fluid and the patient is still unstable, you need to give um, packed red blood cell. Very, very important. So you don't continue to be giving um, isotonic crystalloid so that you don't even tilt towards hyperchloremic metabolic acidosis. So you need to give um there are so many problems actually with giving a lot of isotonic fluid. So the coagulopathy from there, the acidosis from there, the hyperchloremia, you know. So you don't want that to happen to the patient, and you need to quickly transfuse red blood cell, and you need to look for the source of bleeding. So um, ideally, ideally, you are supposed to give after you have given 4 units of packed red blood cell, you have to give 1 unit of FFP, you know, or else you are dealing with severe trauma, with massive blood, loss, or a patient with obstetric bleeding. So in that situation, you have to do a 1:1:1 ratio of transfusion. So because in patient with obstetric bleeding, in patient with trauma that they are having massive bleeding, um, they are losing like whole blood, right? Platelets, plasma, everything, red blood cell, everything is going. So you need to give them 1:1:1 because you are going to prevent so many problems. You know, you are going to prevent coagulopathy, you are going to prevent acidosis, you know, you are going to, prevent so many stuff. So that's just the protocol for massive blood transfusion. So whenever you need to give massive blood transfusion, you are giving like 10 pints of red blood cell within 24 hours. You are giving like 5 pints within 3 hours. Massive blood transfusion, particularly in people with obstetric bleeding or trauma, you know, hemorrhagic loss from trauma, you need to give 1:1:1. So if there's any other situation, then you might give your FFP after you have given 4 units of packed red blood cells. So we should have that at the back of our mind. So um yeah, so that is a ratio. That's the ratio for massive blood transfusion. One for the FFP, one for the platelet, one for um, the packed red blood cell, so that you can just mimic the normal blood composition, right? So you are giving your platelet, you are giving your fresh frozen plasma, you are giving your red blood cell in 1:1:1 configuration. So the next is the tension pneumothorax. So after hemorrhage, tension pneumothorax is the next common, cause of death. And we have said it. How you are going to identify that? Number one stuff is going to be the unilateral breath sounds. So you are going to notice that breath sound is decreased on one side and it's okay on the other side. So that side where it is decreased, that's likely to be the problem, right? And when you do your percussion, you are going to notice hyperresonance in that side. So hyperresonance, decrease unilateral decrease in the breath sounds. So what is going to make it suspicious for tension is now when you see your tracheal deviation, because it's going to be pushing it to the contralateral side. So if there is tension pneumothorax affecting the right side, there's going to be decreased breath sounds in the right side. There's going to be hyperresonance because it is air that is there on that same right side. And that area is going to shift the mediastinum, the tracheal, towards the left side. So there's going to be a left tracheal deviation, right? There's going to be a left tracheal deviation. And because of the increase in intrathoracic pressure around that area, it's going to compress on the mediastinal structures, intrathoracic structures like the IVC, the SVC, they are going to be kinked, and there's going to be reduced, preload to the to the heart, so causing hypotension. So that's why you get, you know, an obstructive shock. The hypotensive, they have tracheal deviation, there's reduced oxygen saturation. Of course, it's more like only one lung is working, right? And there is, unilateral decrease in breath sound and hyperresonance. So what you want to do initially is to do a needle decompression for immediate stabilization before you now later place your chest tube for definitive management. So what I want to say here is that, because you might get it in question, is that when you place your chest tube and you still notice massive air leakage, into your chest tube, think about tracheobronchial tree rupture, because that is going to be like you're opening the tap. Here we just be leaking from the trachea, the bronchial airways directly into your chest tube. So think about tracheobronchial tree rupture when you have continuous air leakage into your chest tube, right? Very, very important stuff. So you don't need to wait for chest X-ray, because there's a tension in pneumothorax. The patient can go off at any time. So you don't wait for your chest X-ray. You go with your own clinical reasoning. You have done your investigation. You have done your not investigation. You have done your examination, and these are classic for an individual with tension in pneumothorax. So you don't need to wait for X-ray. Don't ever pick X-ray in the question stem first. No, do your needle decompression first, right? Not even chest tube first, needle decompression, especially when it is tension. So what you are going to see on X-ray, if you later now do the X-ray, what you are going to see is hyperlucency of the affected area. There's going to be flattening of the diaphragm on that area. Um, from the diaphragmatic contour is going to be lost. You can appreciate the visceral line, although the visceral line here is not very evident here, but we can see the hyperlucency. This area looks blackish more than this area, and you can see the lung collapse. So this is a lung that has already collapsed. Here we can see the obliteration of the diaphragmatic, contour. We can see the tracheal deviation, shifting to, that should be the right. You can see the trachea shifted to the right, the tracheal deviation. So those are the classic findings on X-ray for an individual with tension pneumothorax. And the last one is the cardiac tamponade. So an individual that has cardiac tamponade, we already know from our step one, the Beck's triad, which is the hypotension, the muffled heart sounds, and the jugular venous distension. So you can confirm with the ultrasound, right? So confirm with the ultrasound. So you suspect cardiac tamponade if there is the hypotension, the muffled heart sounds, and the jugular venous distension. So confirm with your ultrasound. Then you can do your prompt surgical intervention by doing, pericardotomy. You make a pericardial window to allow, just like opening a small part of the pericardium, to allow the drainage of the fluid. Or you do your pericardiocentesis, you just keep, you open the small part and you keep aspirating, right? Um, allowing the fluid to drain out. Then, or you can do your thoracotomy, right? So most of the time you are going to see any one of these in the questions. But most of the time they talk about the pericardectomy or the pericardiocentesis, in the question stem. Those are the two common ones that they usually talk about. So this is the ultrasound showing the cardiac tamponade. And one little key fact here is when you cannot secure IV access, after multiple trials, you might want to go to the bone and set, you get your fluid delivered through an intraosseous line. So the after the circulation, the next is the D, which is what, deformity or deficit. So here we are just concerned majorly about your neurologic evaluation to rule out traumatic brain injury. That's basically what you are doing. And what you want to do is just your GCS, yeah, your pupils, yeah, then the spinal cord function, which is the motor, the sensory. So you check your GCS, you know, then the pupillary examination, right? The pupillary reflexes. Then for the spinal cord function, you want to check for the motor and the senses. in the extremities so that you can have the sensory level or to know which areas of the motor movement is compromised. Um, then that is just about your deformities and your deficits. Just the GCS, the pupils, your motor, and your sensory function. Then exposure. So from here now, if you are noticing any neurologic deficit, you might know that okay, there's a tendency that this patient might need a CT scan without contrast, right? That's the way it works. So exposure, exposure. So you are just trying to open that patient, you remove the clothing, to check for any visible injuries, you know, you measure the body temperature, you do a log roll evaluation of the patient. So what you are doing in the log roll is just um we can watch a video on it if we have time. You are just having like three people, having their hands on the shoulder, the hip, the legs, with some of them crossed over one another, and you are rolling while somebody is at the command, stabilizing the neck of the patient. So that's the person that is doing the cervical stabilization. And on the command of the individual doing the cervical stabilization, you roll the patient to a side, like towards maybe like the right side, and there's somebody that is going to, palpate the spine along the cervical spine downwards to see if there's any step of injury, any fracture, any tenderness, around that area. So from there, you can pick up any step of injury, deformities. Maybe there's a vertebral compression fracture, a spondylolisthesis, you know, from the trauma. Then that's part of what you do in exposure. So that's part of what might be missed. So if you don't expose the patient, you might miss it because the patient is going to be resting in the back. So you need to expose to do all those ones. Then you can do your DRE to assess for this mistake too, right? So if the patient is hypothermic, you might want to give one blanket, just like we have said in our discussion of the hypothermia section. Um, So from your palpation of different pulses, you can have an estimate of what the systolic blood pressure is. So the first to disappear is the radial pulse. The second is the femoral. The last is the carotid. So if you can feel somebody's radial pulse, it means that the systolic blood pressure is at least 80. So it means that the systolic blood pressure is at least 80 when you can feel the radial pulse. If you can feel the femoral, it means that it is at least 70. If you can feel the carotid, it means it is at least 60, right? So once you have done all this, we are done with the primary survey. Then we move to the secondary survey. So this is after the ABCD approach, then you conduct a thorough, full head to toe examination. You check everything head to toe so that you are not missing anything. Then you can start also doing some adjoints, you know, to your survey. So the adjuncts we typically do are just like some imaging quickly, that you are doing alongside with your survey, to pick up one or two things based on your suspicion, right? So you might want to order a chest X-ray, um, X-ray of the pelvis, or a focused abdominal sonography for trauma. So this is more like an ultrasound scan of the chest, of the heart, of the abdomen, of the pelvis, right? So that you can detect any fluid collection within these areas, and you can act appropriately. So depending on the mechanism of injury of that patient. So if the patient has a problem with their pelvis, pelvic injury, do your X-ray of the pelvis, problems with the chest, do your chest X-ray. Although most of the time you want to order, someone that has trauma because there's a high risk of the chest, the pelvis, and the abdomen being involved. So you might want to do these three, the chest X-ray, the X-ray of the pelvis, and the fast to assess for any collection within the heart, the lungs, you know, because sometimes you might have hemothorax or pneumothorax that that um, that might be missed on the examination. So that will be picked with your sonography, right? So you might also, want to order some pertinent labs depending on the mechanism of injury. right? So if the person has trauma and the person is bleeding, you want to do your complete blood count, liver function text, EUCR, right? Um, if it's a case of intoxication overdose, you might want to do your toxicology screen, right? You might want to check for your arterial blood gas. Maybe the person has carbon monoxide poisoning or something. You might want to check for arterial blood gas, lactate, base deficit. And of course, that is the time to also start taking the history of the patient. So if it's trauma, severe bleeding, you want to type and group cross match, all the patient of concern. Um, you know, you want to ensure that you have the blood ready to transfuse them when it's necessary. Um, you also need to put in urinary catheter. So as you are transfusing blood, you are giving fluid. The next thing is to insert your urinary catheter to monitor urinary output, because that is part of what is going to tell you that the patient is out of shock, right? Particularly in the hemodynamically unstable patient. So it's going to guide you that this patient is out of shock or how well the patient is doing, or those in surgery. So to know that you are not tilting them towards AKI. So monitor the urinary output. Make sure it's adequate, at least 0.5 ml per kg per hour. Very important. But sometimes if a patient has a pelvic injury and you are seeing hematuria, blood at the meatus, scrotal hematoma, high riding prostate by the time you do your DRE, high riding prostate, those are features of, urethral injury. You might not want to pass the catheter for that kind of patient. So that kind of patient, you might want to order a retrograde um, uretrogram first, right? You don't pass your catheter for that kind of patient. So that's just by the way. And patients that has already been mechanically ventilated, you might want to give them the orogastric tube for feeding, for medications, and the likes. So, for people that are hemodynamically stable, you now want to start doing your CT finding. So one thing I always say about the CT is that in 90% of the situation, if the patient is unstable, don't pick CT because you need to inject dye, you need to, so it's not something that is straightforward. CT even takes a lot of time. So it's not something you want to do for a patient that is unstable. So it's just like a cheat code for you. So once you say that a patient is unstable, don't think about CT in your question, in the option. Don't pick anything related to CT. Most of the time you'll be wrong. So in patients that are, hemodynamically stable, and maybe they have history of maybe hitting the head or against maybe something, or they have some neurological deficit by the time you are doing your your disability check under your primary survey. So that kind of patient, you might want to do CT of the head, non-contrast CT of the head, particularly those with history of head trauma, loss of consciousness, altered sensorium, facial injuries, skull injury, neurologic deficit, just like I said. So you get a history that there's head trauma, they are not conscious, they have altered sensorium, you know, uh, they are drowsy, they have history of facial injury, skull opening injury, like neurologic deficits. All these kind of people, they definitely have to get a CT of the head to further evaluate for injury to the brain that is life threatening. Very, very important. They could have maybe some hematoma somewhere like that you need to rule out. So you need to do your CT. Very, very important in any of these, in any patient with any of these. Then the important one is also the cervical spine. Cervical spine is very important. Should be one, part of what you consider when you are doing your airway treatment in the what's it called, the primary survey. But if, just like I've said, if you might want to do an endotracheal intubation, you might need to do a manual stabilization. But if you don't need to do your airway, if you don't need to do your endotracheal intubation, you might wear them cervical collar spine, cervical spine, yeah, collar rather. That's just my point. So because if you wear the collar for an individual that needs to be intubated is difficult. So if the patient doesn't need intubation, you can wear the collar until you rule out cervical spine injury, right? So that is just one thing about cervical spine stabilization. But you might need to do a CT cervical spine imaging for individuals that are less than 60 years and they fulfill criteria of NSAIDs. So that's the way I kind of you know remember it. So you don't do it routinely in people that are more than 65 years, 60 years because it's not very sensitive in those guys. So it's not reliable. It's not reliable in individuals that are more than 60 years. But in any individual that is less than 60 years and have any of these, you must do your cervical spine CT. So NSAID is the acronym. The hen, let me see, the hen NSAID. So, so the hen is talking about the neurologic deficit, right? Neurologic deficit. Um, sorry, just 1 minute. So the N for the knowledge deficit, the S for the cervical spine tendon. So the spine tendon, the H is for the altered mental status or the altered sensorium. The I is for the intoxication. The D is for the distracting injury. So when we say distracting injury, what we are essentially talking about is the fact that the patient is having some um, injuries that is causing pain that might want to distract them from even talking about any cervical spine issues, right? Maybe there's a degloving injury in the hands or there's a bone injury to the legs, you know, that can distract from, even considering the spine. So, so that is one thing we have to have at the back of our mind. So any other injury to the body that's inflicting pain is a distracting injury. So the neurologic deficit. So a patient less than 60 years having neurologic deficit, having cervical spine tenderness. By the time you are doing your palpation, the step of stuff, the log roll stuff, and you are palpating the cervical spine and its tenderness. Consider cervical spine CT. Outer sensorium, consider cervical spine CT. Um, Intoxication, consider cervical spine CT. The D is a distracting injury, and they must be less than 6 years. So this is part of the National Emergency X-ray Utilization Study criteria, for the need of cervical CT. So you don't do it for all the patients, right? So it's only patient that meet any of these criteria. So if you do um, this and you're able to detect fracture, you're able to detect fracture within cervical spine, then you need to do full, spine imaging. You now need to do a full spine imaging if you detect a fracture. So you need to do a full spine imaging afterwards. If you detect a fracture with your cervical spine, um, CT rather. So just like I've mentioned this, so patient with urethral injury, you must do a retrograde urethrogram first before you know any other thing. So moving on to specifics. So we are looking at because two major form of trauma, penetrating and blunt trauma. So penetrating is just when you have like gunshot, stab, something that is sharp penetrating into the tissue, right? So um so we are looking at the cases one by one. The head first. So penetrating injury to the cranium or the face, right? It usually occur in conjunction with blunt injury. Maybe the person has, motor vehicle accident and maybe the glass, cut through the face and at the same time smash the head on the steering. So smashing the head on the steering is going to be a blunt injury, while the glass breaking and inflating laceration injury is going to be like a penetrating injury to the head, right? And both of them can cause some catastrophic um, injury to the neurologic system. Um, if the patient is hemodynamically stable, just like you can see, if the patient is hemodynamically stable, you need to do emergent non-contrast CT of the head, of the brain, to assess the extent of the intracranial injury. If the patient is not hemodynamically stable, so you go and do your primary survey quickly, right? ABCD approach quickly, stabilize, secure that airway before you start saying you want to be doing um, imaging. So that's the approach. But if the patient is hemodynamically stable, then you might do um, your CT to look at um, the extent of the intracranial injury. So if the patient is not hemodynamically stable, please don't pick CT. So make sure that the patient is hemodynamically stable first before you start talking about CT scan. So because we are looking at penetrating, so there's like sharp, there's tendency for laceration. So you have to evaluate for any facial, laceration, and we are majorly concerned about the nerves, right? The nerve that supplies the motor function of the face, which is the facial nerve, right? Controls the orbicularis oculi, the bossinator, the risorius, all the muscles there. And also the nerve that supplies the sensory, which is more like the trigeminal. So there's a tendency of cut through this nerve. So you need to do your examination and see if there is, appropriate function of all these nerves. And part of what you are also going to check for in the CT imaging that we are going to do is to look for, injury to any of the facial sinuses, which is a possibility from, trauma to the face. So if there's any form of facial laceration, you need to repair it. You need to just do a irrigation, you clean that wound, and you are going to do a repair. You suture it by primary attention. Very easy. Very, very easy. So that's what you do. So a patient with facial trauma, laceration. So if the patient is hemodynamically stable, you do your CT scan to evaluate for any intracranial, brain injury, right? If the patient is not hemodynamically stable, you make that patient hemodynamically stable. You give your fluids, blood if necessary, check the airway and the likes. Then you do your imaging. Then if there's laceration, you repair it, right, by primary intention after you have done a copious irrigation and washing of that injury. Is there anything I'm missing? Yeah. So, and of course, you also have to assess for the motor and the sensory function of the face, the facial nerve, trigeminal nerve. So for the eyes, penetrating injury to the eyes is highly associated with open globe injury. Um, and there's a tendency of even retention of foreign body within that eye. So what are those features that you are going to see that is going to raise suspicion for open globe injury? So you can notice impairment of the vision. So you can see reduction in visual acuity or even relative afferent pupillary defect. I know we have talked about that in our neurologic section. And you can notice gross deformity of that globe. Just see that the globe is kind of the high ball is deformed in a way. You can notice either reduction in the volume of the globe or protrusion of the globe content. So either the globe content is protruded or there is a reduction in the volume due to loss of the globe, right? Or you look at the pupil, you see that there is an eccentric pattern, or teardrop shape of the pupil. So we can check that. Can just type it in Google, see what teardrop shape pupil looks like. You just see it looking eccentric, like a teardrop. So you can also notice leakage of vitreous humor. It's also a sign of open globe injury. So leakage of vitreous humor, teardrop shape pupil, volume loss or protrusion of the globe content, you know, reduction in visual acuity, gross deformity, all these things is talking about open globe injury or rupture. So you might want to do a slit lamp examination. So just like I have here, you can do a slit lamp examination to check for the anterior segment, or you can do, and you must also do a fundoscopy to look at the posterior segment. But if on your examination you notice that there is open globe injury feature, you don't continue with any examination. So at that point, you stop examination. You don't do any more investigation. Very important stuff. You don't do any more examination stuff. Like, and before I move from there, I also need to talk about the Siddle sign. So these are under test that backs up the globe injury, the open globe injury. And what you do here is just you inject fluorescein. So you inject into the anterior chamber, and if there is open globe injury, there's going to be wash out of that fluorescein that is going to be washed alongside with aqueous humor out of the eye. So once you see that leakage, you know that there's tendency of open globe injury. There's even open globe injury. So sometimes you might also see hyphema of the anterior chamber. So that's like blood collecting within the anterior chamber of the eye, you know, and they are highly associated with orbital fractures. So what I'm just saying here is that any of these cardinal signs, reduction in visual acuity, relative apparent pupillary defect, protrusion of the globe content or reduction on the globe volume, um, teardrop pupil, positive CDF sign. You put your fluorescein dye, it's leaking, it's washed out with aqueous humor, open globe injury. Stop your examination at that point. So the next thing is to do is to give analgesic for pain, because that condition is going to be very painful. So you don't want to inflict any more um, tension, or stress to that globe. You don't want to apply more pressure. So what you do is just you calm the patient, you give sedative, you reduce the pain, you give analgesics. You don't want the patient to vomit, so you give antiemetics. So three things you give. So you provide the patient with antiemetics, you know, you kind of sedate the patient, and you give analgesics, for the pain, so that the patient doesn't cry or vomit, right? Because this can further increase the pressure within the globe and can lead to evisceration of anything that is there. So you don't try to retract the eyelid. You don't do any tests like tonometry, you know. So because you don't want to inflict more pressure. So what you just do is you just do a non-CT contrast imaging of the orbit, and you do a surgical repair within 24 hours. Basically, that's what you do. That's what you do. But lacerating injury to the globe is highly associated with orbital fractures, right? And there's a tendency for entrapment of the inferior oblique and the inferior rectus muscle, so leading to restricted eye movement. You can just notice that there's the movement is only restricted to the lower gaze or upper gaze, depending on which muscle is affected. So if it's inferior oblique, it means that the person will not be able to move the high ball upward, so they will be restricted to a lower gaze. If it's inferior rectus, they will be restricted to the upper gaze. So you can also see that entrapment, with your CT scan. So that entrapment of this muscle can actually trigger what we call the oculocardiac reflex. So this is one thing I want us to pay attention to. Um, so um, um, when there is like a tension on the globe or stretching of the extraocular muscles, there is activation of this oculocardiac reflex, and it is talking more about um, uh, 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 connection of the trigeminal nerves, particularly the ophthalmic branch of the trigeminal nerve with the vagus nerve. So they share a connection at the ciliary ganglion. So when there is pressure on the globe, there's activation of the efferent side, of this reflex, and that is the ophthalmic branch of the trigeminal nerve. It's been activated. It sends signal to the signal ganglion to activate the efferent side, which is the vagus nerve, and that is going to send parasympathetic stimulation to the heart, which brings about slowing of the heart. So you notice that the patient will become bradycardia, they can have nausea, vomiting, and even they can even go into cardiac arrest, asystole. So what you want to do is to do a surgical intervention to quickly detach that entrapped muscle, or you can give atropine or glycopyrrolate to block, that vagus stimulus. So, but the definitive treatment is to do a surgical release of the entrapped muscle. Very, very important stuff. So don't forget that. Um, for the hairs, for the hairs, so you just want to evaluate, laceration around the hairs. You are more concerned about the hair itself as well as the surrounding structures. So you want to look into the hair with your otoscope. Is there any um, collection within the hair, like blood collection? Is there any tendency for perforation of the tympanic membrane, right? You want to look at the surrounding structures, the mastoid bone at the back of the hair. Is there any hematoma there, which could be indicative of a basal skull fracture, right? You want to look at the structure beneath the hair directly. That is the parotid gland. Is there any injury to the parotid gland? Is there any bruising around that area? Any injury there? Because the facial nerve also runs through the parotid gland. So if there's damage to the parotid gland, there's a high chance of damage to the facial nerve too. So you have to evaluate for that. And sometimes you might notice leakage of cerebrospinal fluid through the hairs, and that's what you call otorrhea. So that is suggestive of basal skull fracture, right? And one way you can confirm is to test for the presence of beta transferrin from that CSF. So beta 2 transferrin is highly abundant in CSF. So once you collect the fluid from that hair and you test the level of the beta transferrin and it's elevated, you know that that's definitely damage to the temporal bone, causing basal skull fracture with leakage of CSF. So that's why you might want to do your CT imaging of your temporal bone, if you are highly suspecting basal skull fracture or any bony involvement. So if there's ulceration in the hair, what do you want to do from the penetrating injury? You want to do a primary closure, right? That's the first line. You have to close it, particularly if there's exposure of the cartilage of the hair. Because the way the hair, the nose, the way they are designed is that there's a cartilage and there's a pericardium. So you have like a dense connective tissue covering that cartilage. So there's the cartilage itself, then there's a pericardium that provides blood supply to the cartilage. So once you notice that the cartilage is exposed, cover that. Just find a way to cover to prevent exposure of the cartilage because there's a high tendency of infection and there's a high tendency of ischemic necrosis of that area because the blood supply will have been compromised. So find a way to reoppose that area so that you can restore the circulation and can limit infection, right? You can limit infection. So that's that about laceration injury to the hair. Think about all these things. Injury to the back of the hair, the mastoid bone, the mastoid process of the temporal bone, basal skull fracture. Think about inside the hair, blood there, ruptured tympanic membrane. All those things might require surgical intervention. Look at the area beneath the hair. Is there damage to the parotid gland, facial nerve? So moving to the oral cavity. The oral cavity is very straightforward. So you are just going to do, your assessment for any form of dental injury. So any form of dental injury, loss of tooth, damage to the gingiva, the palate, or is there any fracture of the midface, the maxilla, the bones that surround the oral cavity, or the mandible? So you might need your CT imaging to diagnose the midface, the maxilla, and the mandibular fracture. We are going to talk about the left foot fracture very soon, and your CT is very important to pick the midface and the mandibular fracture. But the clinical significance of this oral cavity stuff that we must always remember is the fact that in some people they might have their anatomy being positioned so that they have their internal carotid artery running very close to the posterior part of the pharynx. So it runs very close to the posterior pharyngeal wall, and if a child, for example, suffers a penetrating injury to the oral cavity, maybe the child falls on a knife or falls on a pen, and the pen enters straight into the mouth to the posterior pharynx and punctures through, it can easily dissect the internal carotid artery. So we can just get history that there is headache, there is um, neck pain, you know, um, uh, the patient might present with signs and symptoms of Horner syndrome because the sympathetic plexus runs with the carotid artery, with the internal carotid artery. So, and suddenly they put it there in the question center, there's anhidrosis, there's meiosis, you know, we think about Horner syndrome, right? And, you know, basically we might want to, you know, alongside as we are observing, give anticoagulant, give antiplatelet, and if there's a need, you can do a carotid ligation, right, for that patient. So if it's just more like injury to the gingiva, the buccal mucosa, the lips, the cheek, the gingiva, so you might not really need to do a primary closure because those areas are very, very vascularized and they heal rapidly. But there are some things that might reduce their tendency to heal, particularly if there is a large wound that is so difficult, that is gape, so difficult to merge together and oppose. So, for example, if it's more than 2 cm in length, it might be very difficult to, merge together, so it might not heal well. Or if there's foreign body, being trapped within that stuff and it's difficult to even remove. So in that kind of situation, you might need to do a primary closure. So try to clean out those um, debris and oppose because you want to limit infection. Or if the wound is so big, very difficult to self oppose, you won't leave that to heal by itself. So you need to do a primary closure. Or if there is tissue retained within that wound, that's very difficult to cause closure of that wound. So if there is a tissue that is trapped over the occlusal surface, it might be very difficult to close that wound. That wound rather might be difficult to close by itself. That's what I mean. So you might need to do your primary closures by yourself. So tissue, foreign body, and injury more than 2 cm, do your primary closure of your gingiva or your buccal injury. Then moving on to the nasal trauma. Um, so somebody suffers nasal trauma. What I just want us to have in the back of our mind is fracture to the nose, the blood collection, and CSF drainage. So penetrating injury to the nose might cause laceration, right? And injury to the nasal bone too. So you want to do your gross examination, look at is there any deformity of the nose? Like look for any form of malalignment. You palpate for any deformity of that nose. You can feel for crepitus, right? So you have to palpate too for hematoma. And sometimes you might see rhinorrhea, just like we are seeing otorrhea in basal skull fracture involving the hair, right? So there is tendency of the CSF also draining to the nose, rhinorrhea. So you have to check for that too. So the fracture, the gross malalignment, the crepitus, all those ones are for fracture. The blood, hematoma, you feel for swelling. The CSF is when you see, clear fluid kind of draining through the nose. So if you see rhinorrhea, following the nasal trauma, it's an indication that the cribriform plate of the ethmoid bone has been fractured. So that is a part of the nose that forms the base of the skull, the cribriform plate of the ethmoid bone. So it means that there's a fracture of the cribriform plate. So they might ask us in our exam, somebody suffers a nasal injury, laceration, penetration injury, and the person is draining, CSF, clear fluid, and what part of the bone is damaged. So that's the cribriform plate of the ethmoid bone. So septal hematoma is one important consequence that we must always remember. And this occur when there is accumulation of fluid between the septum, of the nose and the overlying pericardium. So pericondium rather. So don't forget, like I said, like that septum contains cartilage, right? And there's an overlying dense connective tissue, which is called the perichondrium. So the pericardium is enriched with numerous blood supply that provides, an extension to the cartilage. So if there is injury, there's tear of those vessels and they can easily bleed into the space between the pericardium and the cartilage. It can accommodate the blood and the compression there can compromise blood supply to the cartilage, leading to ventral necrosis. You know, so you don't want that to happen. So what you want to do is once you feel for the septal hematoma, you know that this is problem. So the next thing is to incise and drain. You drain um you drain the fluid there, and you also have to find a way to pack that area to prevent further reaccumulation, right? Because if it reaccumulates, it provides breathing space for infection, and within like 72 hours, infection sets in, abscess starts, occurring, and it becomes terrible. So you need to drain quickly and you pack to prevent reaccumulation of the fluid. And of course, you have to give empiric antibiotic treatment, right? To prevent, infection from happening. So don't forget, you have to pack, you drain, you pack, and you give antibiotic cover. If there's any laceration, you repair. If there's any laceration, repair by primary intention. So auricular hematoma is also one of those complications of somebody with heel injury that we are supposed to talk about there. It's just the same as in nasal septal hematoma. So there is, you know, um, bleeding into the space between the cartilage of the hair and the overlying perichondrium. So you also have to drain it. You know, you can apply a direct pressure dressing to prevent the reaccumulation of the hematoma, right? If you don't drain it completely, infection can happen, but most importantly, you have ingrowth of fibrocartilaginous tissue. So that brings about a gross deformation of the hair, which you call the cauliflower hair. You can check that up. We see the way it looks like. There's gross deformation of the hair due to ingrowth of fibrocartilaginous tissue from improper drainage of auricular hematoma.